Yeah, thanks for joining us. Thought 2 months after the outbreak in Mexico, it's good to just take stock and share my perspective on this outbreak with everybody. But 2 months later, it has now become a global pandemic. The North American countries, US, Canada, they are less lucky because they were so close to ground zero. So they really had no opportunity to try to contain the outbreak. And the virus just went into community spread very quickly. Whereas down here across the ocean, the Asian countries had 1 week, at least a week, to gear up, to activate the various containment measures at the borders. And they, by and large, put up a very robust response to try to slow down the virus spread for a few precious weeks of preparation time, even though we all knew there's a matter of time and there will be community spread. Australia, Japan, New Zealand put up very strong containment measures and managed to hold up the virus at the borders for about 1 month. Very, very credible performance. But eventually the virus still slipped into the wider community and the number of infected cases there just simply grew exponentially. You may remember that in 2 weeks, Melbourne alone saw figures soar by 1,000 patients within a very short period. And then they, in turn, became a source of many exported cases. If you look at our data, half of our exported cases came from Australia, double the number from US. From our point of view, analyzing our own imported cases, we see 3 waves. The first wave was from America, and then the second wave from Australia. For us, the second wave was a bigger wave, purely because the travel volume between Australia and here is a lot higher than the travel volume between North America and Singapore. And now you will notice, starting from last week, the third wave, which is from our fellow ASEAN neighbors, particularly Philippines and Thailand. I think because of our close proximity, we should anticipate that this third wave may in due course become a big wave. Against these challenging circumstances, Singaporeans are putting up a very good fight against the virus. Many took our advice and behaved responsibly. Many infected cases, because each time when we report the cases, we let you have the details. And you knew that many sought early treatment and did make use of the 993 ambulance service. And many more people, more than 1,000, put up with the inconvenience of home quarantine or quarantine at Aloha. We are all very grateful to them for their social spirit. As a result, we have bought ourselves valuable time. We can be very proud of our achievements. For 7 weeks, there was no local transmission. All our confirmed cases were imported. We were able to track down every imported case and every of their known reported close contacts and isolate them promptly. By now, we have contact traced more than 1,000 people and quarantined every one of them. Our contact tracing teams work very diligently round the clock, 7 days a week, to track down every known contact of the patient. They deserve our praise. However, we know that eventually we will also have community spread here. Some patients don't have symptoms at all, and they can go around infecting others without them knowing it. This is in the nature of influenza virus, and that's why it's so contagious. And it is not because these people are irresponsible. I think let's not blame them. Last week, we have the first sign of community spread, and over the weekend, the signs have become more prominent. By now, we have 168 confirmed cases, and now 26 more than what we just heard from Lee. Local, we do not know of the 26 how many local spread, how many are imported. That is still being examined and analyzed. But if you base on the up to yesterday's data, of the 142, 24 you heard were community spread cases, so that is 17% of the total confirmed cases. This percentage is worth monitoring because that will help us determine what is the extent of community spread. From the experience in Melbourne and also elsewhere is, I think we have crossed a tipping point beyond which the community spread numbers will just simply grow, magnified very rapidly. And this may well happen over the next few days. But our objective remains unchanged, which is to minimize casualties. But as our circumstances change, we must change strategy as well as tactics. When the number of cases is low, so we put a lot of resources tracking down every known close contact and try to isolate them. But once the numbers escalate, we have to shift our resources to focus on detecting and treating infected cases, paying particular attention to high-risk patients. These are the adjustments that we have been making the last few days, and we will continue to make over the next few days. They correspond to a shifting of our alert level from yellow containment to yellow mitigation. The transition will not be abrupt. We will do it gradually, and of course, the pace of it will be guided by actual local epidemiology of the disease. So let me elaborate on what are some of these adjustments that we can expect over the next few days. First, we will take a much more focused approach to contact tracing. So far, most of the contact tracing pertains to air passengers sitting close to confirmed cases. But with community spread, the likelihood of infection has now shifted to the local community instead of only in the aeroplane cabin. So we have started to scale down such contact tracing. Contact tracing henceforth will be decided on a case-by-case basis by our public health experts, taking into account the medical condition of the infected patients while they were on board. Isolating close family members of confirmed cases, however, remains a useful control measure. Likewise, temperature screening at borders remains useful. We know this is not foolproof, but it is useful. If you look at our cases, 1 in 4 of the confirmed cases, imported cases, were picked up by the scanners. Second, we have ramped up our laboratory facilities. So by now, all our major hospital labs are capable of testing and confirming H1N1. Third, we have geared up all our public hospitals to handle H1N1 cases. 993 ambulances have begun sending suspect patients to all public hospitals and not just Tan Tock Seng and KKH. We have also refined our workflow. 993 ambulances now send the majority of the suspect cases judged by the doctors to be mild to go home after their swabs have been taken. And the patients can then rest at home while they wait for the lab results. I think this has made the experience much more humane for these suspect patients. I, of course, expect such people to behave responsibly and to rest at home while waiting for the results, since they are clearly unwell and they really should not be wondering about